I would like to welcome everyone to today's web symposium. It's an international collaborative research program between Osaka University and UC Berkeley. And the topic of today's web symposium is the investigation of socio-economic factors associated with successful assisted living in Japan and the United States. Um, Good morning, everyone. Ohayo gozaimasu. Um, I, my name is Winston Sang, and I'm associate professor at University of California, Berkeley School of Public Health, and also specially appointed visiting associate professor in the Division of Health Sciences at Osaka University. It's my pleasure to welcome everyone to today's International Web Symposium. And today we have also a co-moderator, Professor Mai Kabayama, who is also associate professor at Division of Health Sciences at Osaka University. And today we will have opening remarks from Professor Kei Kamide and also two lectures, including a lecture from Professor Kamide and also one from myself, and also a research report from Ms. Yuka Ohata, and also a special lecture by Dr. Linda Newhauser and Dr. Xiaoming Sun, and some joint discussion and closing remarks. As we get started, first I want to please welcome Dr. Kei Kamide to present the opening remarks and first lecture. Dr. Kei Kamide is a professor of Department of Health Promotion Science and also the Vice Dean of the Division of Health Sciences at Osaka University Graduate School of Medicine. Please welcome Dr. Kamide.
Good morning, ladies and gentlemen. In snowing Osaka, Japan. Good evening in California, United States. So thank you very much for participating in Osaka University and UC Berkeley Joint Web Symposium 2021. This joint symposium is a link of 2020 international collaborative research program between Health Science Division, Osaka University Graduate School of Medicine, and School of Public Health in UC Berkeley. This collaborative research program title is Investigation of Socio-Economic Factors Associated with Successful Assisted Living in Japan and the United States. Healthy aging is the most important theme, both in Japan and the United States and all over the world. However, aging is the most important, however, life expectancy of human is supposed to be maximum 120 years. Everybody, even people with healthy aging, has a decline of physical and cognitive function by aging. Therefore, we have to think about the long-term care to realize the wellness of assisted living in the future of healthy aging. For such a successful assisted living, socio-economic factors associated socio-economic factors associated with successful assisted living is thought to be important. The School of Public Health, UC Berkeley, has a lot of researches of socio-economic factors for health. So we collaborated in this program to investigate the factors associated with successful assisted living, focusing on the socio-economic factors. In this web symposium, we understand the current situation of aging society, healthy aging, and assisted living, and discuss about the wellness of all the life, even in assisted living. We invited three famous professors from UC Berkeley in this research field. I believe this symposium will be very useful and informative for healthy aging and geriatric research to realize the long-term care for successful assisted living. Please enjoy the symposium today and day 2, January 19th. Thank you very much. So I will start first presentation. Okay, so I show the slide, my slide. So I would like to talk about current situation of aging society in Japan, importance of healthy aging, and successful assisted living. Japan is one of countries with highest life expectancy in the world. In Japan, we have already faced the situation that we concern its super aging society. In 2019, as you see, the mean age of male, average age of male is 81.4 and female is 87.5. And we expect that our life expectancy in 2060 will like 84.2 of male and 90.9 for female in Japan. People age higher 65 years will be about 40% of total population in 2060. So we can say one support, one error is coming in the near future. As you know, Japan is a front runner of super-aged society. At 2015, Japan is only one country where the proportion of the elderly is 30% or more. WHO predicts that about half of Japanese will be 60 years or older in 2050. During these 35 years, super-aged countries are increased in Europe and Asia, such as China, Korea, and Taiwan. In Japan, we are faced with Japan's 2025 burden. The year 2025 is when baby boomer generation becomes 75 years. Estimated number of very elderly population aged 75 years is about 20 million at 2025. And the percentage of very elderly population will increase more and more due to falling birth rate. The percentage of the elderly over 65 years is 28 or more now, and will reach more than 30% at 2025. Oldest old population is almost increasing, most increasing in Japan. As you can see, only 90 years and 95 years old will be increasing both in male and female in Japan last 10 years. This slide shows life course of human. All of human has physiological aging, in which physical and cognitive functions are declining. If people had age-related disease, their functions are rapidly declining, which is called as a pathological aging. Disease prevention and preventive care are important for protection against these two types of aging. But there are some aging phenotypes in the oldest old. We have to focus on this time to realize successful assisted living in this area. About the reason that Japanese people live longer, social insurance system in Japan could be contributing on increasing life expectancy. Our medical insurance for all of nations start in 1961. Free medical fee for all patients over 65 years started at 1973, when rate of elderly was 7.1%. Since number of elderly patients and old people with disabilities are increasing, long-term care insurance system was started from year 2000. This is outline of long-term care insurance in Japan. People ask the application to city office by themselves. City officers check their status of cognitive and physical status and so on. The committees for long-term care insurance assesses, decides the over criteria or under criteria and give certification of long-term care service with a level of long-term care. There are many services for people with disabilities. People can choose according to their disabled status. Their care plan is basically made by care manager. This health insurance system is supposed to be a good system and playing a role to longevity country, but cost of medical and long-term care insurance are increasing very much. This will be a serious problem in Japan. These figures show how many persons are supporting elderly health insurance. About 50 years ago, one elderly was supported by 9 full-age peoples. Medical fees were free for elderly. But in 2025, 2 young and middle full-age persons will support one elderly. That is called as 2025 burden. It seems to be the big problem. Thus, the extension of healthy life expectancy, so-called as a healthy longevity, is desired in Japan. There is a gap about 10 years between healthy and average life expectancy. So it's supposed to be very important to clarify the factors associated with, the factors contributing to the healthy life expectancy. This gap is not shortening easily. So I think how to live in these 10 years are a very important issue. Upper figure shows that rapid increase in the older population and continued low birth rate cause changes in demographic structures and shrinkage of working population. This slide shows an example, the Japan's case. The life course is a continuing that diversity in old age is not random. Only a very small population of old people who actually require care and support. Not all of non-elderly people actually in the workplace. The lines of artificial difference should be removed and understand the future society as a continuum that where there are some people's old ages may be very robust and healthy, and others who might require some care and support. This slide shows the elderly health promotion by Japan's Ministry of Health, Labor, Welfare, Kenko Nippon 21 second edition. Ministry appointed local government to manage preventive care for the old older frail people by focusing on the improvement of the physical function, cognitive function, and malnutrition status. As mentioned in elderly health promotion by Japanese Ministry of Health, Labor, Welfare, exercise, nutrition, and social participation are important for each individual to be healthy, aging, and longevity, clarified by our study and some previous study. Medical care should contribute on the management of lifestyle-related disease. I believe these three factors, exercise, nutrition, and social participation, would be also important for the achievement of the successful assisted living. Recently, number of people with right certification of long-term care insurance and increasing. These people are frailty status. What is the frailty? Yeah, I would like to introduce concept of frailty and the reason of focusing on the frailty. A frailty is an intermediate state between robust and disabilities. In older adult. A frail older adult are high risk of adverse clinical outcomes such as falls, fracture, hospitalization, and so on. Therefore, we have to make effort to prevent frailty, to prevent progression to disabled status, and recover frail status to healthy status. There are several criteria of frailty. Freed proposed that frailty is defined by 3 and or more of 5 items as shown here. And unintentional weight loss, feeling of exhaustion, low physical activity, slow walking speed, and muscle weakness. There is no item related to cognitive function. We should screen the people with frailty area and have to be have some intervention. Based on this background, Japanese Ministry of Health, Labor, Welfare started to emphasize on preventive care for old people at high risk of needing future care and support for people with disability. Primary and secondary prevention is supposed to be preventive care. Tertiary prevention is generally in the long-term care. In Japan, lots of studies about preventive care are performed right now. In contrast, studies about long-term care for people with disability or assisted living are limited. However, most increasing age generation is over 85, 90 years old. These super-aged old people mostly need some support. From now, we have to think how we support for keeping their wellness. This slide shows the structure of every city or town called the core community-based integrated care system should be established. That comprehensively ensures provision of healthcare, nursing care, prevention, housing, livelihood support. By this, the elderly could live the rest of their lives in their own ways in environments familiar to them, even if they become heavily in need for long-term care. About medical system, home medical care is most desired in this system. So I am doing home medical care by doing visiting patient care in around Osaka University, Sandy Newtown area. So I'm going to check my patient once a week or once 2 weeks. Also, emergency visit anytime for 24 hours. So this old lady, is a dementia. It's living alone, and this old male patient, he has a wheelchair, but he's living alone. So we need help for him. So visiting nurse is very common in home medical care. They are doing mostly medical nursing care for home medical patients. And rehabilitation by occupational therapist, like that. And physical therapist is doing for the rehabilitation. Aim of home medical care by medical staff mostly support patient daily life, care for chronic diseases, maintain residual function, mental care, secondary prevention for disease and geriatric conditions, emergency treatment for their acute disease, connection to various services, enlightenment information to patient and caregiving family, caregiving families' health care, maintain team collaboration for the patient, and end-of-life care. So this shows the home medical care team. So patient in the center, home care doctor, visiting nurse, and the care managers are essential. So if patient needs some other services, sometimes pharmacist going to the home, nutrition, physical therapist, or occupational therapist, visiting dentist. So going to their home. Of course, sometimes they are living alone, but most of cases, caregiver, caregiving family, there is a caregiver. So we need to care for caregiver. So now we are doing a home care study. So it's called Osaka Home Care Registry Study or Care Study. Data for this study were collected in our cohort study, OCARE. OCARE is a prospective cohort study including elderly patients receiving home-based medical care in Japan. Cooperative clinics, 8 home care clinics in Osaka and Hyogo area. OCARE started on 2015, and we collect follow-up data every 6 months. We collected data by investigating clinical records by registered nurse. Data details were basic information, service information, and research-oriented information. So we collected the data about the home patient with home medical care by a nurse, and making a big database, and we analyze the data and feedback to the home medical clinic, home care clinic. So OKR database includes 3 domains: basic information, service information, and research-oriented information, such as the decision of end of life, factors about polling, acute care, etc. This is the very first year's background data of OKR. So female dominant, about subject age, most half of them are over 85 years old, very old. And care level, so 2/3 of the patient with care level over 3, very disabled. Background data, another background data. So over 70% had dementia. About 80% had lifestyle-related disease, include cardiovascular disease and cancer. Living style, so 60% with family, 31% it's living alone. The 40% from 45% from hospital to the home medical care, 41% the regular hospital care and home medical. Research target in OKR study, clarify factors associated with continuing home care. For example, poor misaspiration, dementia, dehydration, malnutrition factors, and factors associated with accelerating level of long-term care, and factors associated with discontinuing home care and good end-of-life care. This information will be useful to establish better home care system and community-based integrated care system for successful assisted living. This is recent data, published data from OKR study. So long-term care assisted long-term care level, the factors, deteriorated factors, bone and joint disease. So we need the rehabilitation for home medical care patient is very important. And disease factor, low serum albumin. So we think important. The nutrition factor is very important in home care. So just previously I said, so 3 pillars for successful assisted living. It's exercise, rehabilitation, nutrition, and social participations. I think very important for successful assisted living in home and elderly care facility. So maybe additionally, so I think socio-economic factors will be very important in this successful assisted living. So this is final slide. So we started international collaborative research program from 2020 between Osaka University and UC Berkeley. We have some field and some data about assisted living. So include OKR. The NOCE study is just last year started whole town intervention study, include all people. And through the data, it's a big data, a COCO database, it's including a long-term care insurance. But we have not much experience for the socio-economic factors analysis. So UC Berkeley School of Public Health researchers has established community health and socio-economic studies experience. So we collaborated and we start this study and collaborative program. So finally, our research project proposed a strategy to realize the successful assisted living. I hope. So this is the last slide. So this is, we are going to the Nose town. We started Nose study last year. So the beautiful the morning pictures. So thank you very much for your attention. Enjoy the rest of our symposium. Thank you very much.
Thank you very much for the wonderful presentation, Professor Kamide. So, um, shall we discuss some or go into next presentation?
I think it's no time.
Okay, so maybe we will have some discussion after all the presentation.
Okay.
So maybe next, I will proceed the next presentation. I'm happy to introduce Professor Winston Sen, and he's an associate professor of research of community health sciences, School of Public Health lecturer, Asian American Asian Diaspora Study Program, Department of Ethnic Studies, associate director of research, Health Research for Action Center. And he's now also working as specially appointed professor of Osaka University Health Sciences, and he's leading the research project of the collaborative research of investigation of socio-economic factors associated with successful assisted living in Japan and the United States. So please start, Professor Winston.
Thank you for your introduction, Professor Kabayama. And it's certainly an honor and a pleasure to present about healthy aging among older adults in the United States. As part of this work, also, I wanted to also well, introduce Professor Linda Newhouser and Professor Marlon Maus, who is also working with our UC Berkeley team as the lead faculty who is working on this project together for the symposium, but also for this 23-year project. For me, I am an immigrant to the United States from Taiwan, but I have been in the United States, San Francisco Bay Area, for 40 years now. And time flies quickly. And I'm a medical sociologist by training and have been a faculty at UC Berkeley for 15 years. And certainly multicultural health and aging is a focus I'm very interested in. And aging is really a global issue as it grows more and more across the world. We know today the aging population, 65 and older, is the fastest growing group by age around the globe. And Linda Newhouser is actually our Director of Health Research for Action Center at UC Berkeley School of Public Health. And also it was founded by Len Sine, who's the father of social epidemiology back in 1988. And we think of research and also health interventions together. So we feel research alone is not sufficient. It has to have some practical purpose. So our team includes researchers, practitioners, and communicators. And we work closely with communities, government, businesses, and more, because we can't do this alone. We need to do this together as a community. In this presentation, I will talk about what is healthy aging from the US perspective, and also about aging developments in the US and some US policy recommendations. So what is healthy aging? And this is something that is evolving in the United States as well. The CDC, Center for Disease Control and Prevention in the United States, initiated a project in 2000, a Healthy Aging Network, to really think about what is healthy aging. And it's defined as the development and maintenance of optimal physical, mental, and social well-being and function among older adults. And it's really achieved through a combination of the physical environment, communities, and also health services and community programs. So it's really an integrated model thinking about healthy aging. An initial focus is on older adults. And in the United States, we think about older adults as age 50 or older. And actually today, I think we're moving more towards 45 and older. So what is an older adult? Continue to change from 65 and older, 50 and older, and perhaps now even younger in the United States definition. And it's really based on what we call a socio-ecological model of aging, this new concept of healthy aging. Certainly as individuals, we don't do this alone. It's also, thinking about individual knowledge, skills, attitudes, and self-efficacy, but it's also interpersonal, social support systems, social networks, also institutional in terms of organizational regulations, rules, and also community organizations, groups, and the physical environment, and also public policy, laws and policies at local, state, and national levels. It's really, all of these issues is critical to healthy aging. And this healthy aging network that the CDC initiated around 2000, UC Berkeley was part of this healthy aging network under Dr. Bill Satriano through about 2014. But we continue to certainly support the work through this network. And one of those components that we really worked on nationally was thinking about cognitive health. So there was a brain health initiative as part of this healthy aging network, really thinking about this critical issue a little more than 10 years ago to really rethink, besides, healthy nutrition, physical activity, and social engagement, how do we think about, supporting cognitive health? And this was a large study of more than 75 focus groups. And what I will be presenting on for this study is really part of the results from 42 of the focus groups with older adults, including white, African American, American Indian, Latino, and Chinese and Vietnamese. What is successful aging? And a question we ask is, what is aging well? Asking, and to the different participants of different cultural groups, it's a range of things, living to an advanced age, social involvement, a good attitude, good brain health, physical health, and spirituality. These were some of the key findings of what is considered aging well among the older adults we interviewed. And some of the examples were, for example, the Chinese Americans and Vietnamese Americans, they often talked about kind of the balance between mental and physical health, but also kind of more dependent or more family dependent and not really independent living like the whites in America. And then certainly among Latinos, there was also a talk about, besides living to an advanced age, also thinking about mental outlook and spiritual support as critical components. And then some of our results also showed American Indians, whites, and African Americans talks about really the importance of social involvement. So different focuses for different groups, but I think certainly all the various issues are important. And one of the things I wanted to highlight is one of the Latino participants who spoke, you know, he said, if you have a good mind and the brain is functioning properly, you could be confined to a wheelchair and still be joyous. So as, older adults, healthy or frail or become more challenged, I think, perhaps, rethinking what is healthy aging, if one can have a positive mental outlook and a good spirituality, perhaps, these declines will be, less stressful, less challenging for both the older adult, but perhaps also if there's a rethinking of what is healthy aging, also for the caregiver and those around the older adults. Next, I wanted to talk about aging developments in the United States, kind of where we are today. And some of the most common areas affecting US population size, similar to, in Japan in many ways. The baby boomers is a group that we're very concerned about. This is the group currently that is aging with the largest older adult population. And certainly as the life expectancy increases, there was a tremendous increase over the past century, and also issues of global migration in the United States. These are some of the major factors. By 2050, it's anticipated that Americans 65 and older will number 89 million people, more than double the number by 2010. And the rapid growth, certainly, besides the baby boomers, in the next 20 years, roughly 10,000 Americans will celebrate their 65th birthday every year. Each and every day for the next 20 years, about 10,000 Americans will celebrate their 65th day each and every year. And we estimate there will be about, by 2030, 1 in 5 Americans will be an older adult, 65 and older. And looking at the population today, it's becoming more and more diverse. As you can see, the population of non-Hispanic whites in America is declining. At the same time, the other people of color are growing. And we estimate by 2050, about a little around 40% of Americans will be non-white in America. So it's becoming more diverse, and there may be more cultural differences in how do we care for older adults as time moves forward in the United States as well. And certainly some of the main chronic conditions, leading cause of death, certainly due to heart disease, cancer, and certainly this cuts across all the groups, not a surprise. And certainly Alzheimer's and dementia is also growing in terms of issues as leading cause of death compared to, let's say, 30, 40 years ago. It's become an emerging issue. And certainly, for those who, are older adults, it's often common to have multiple chronic conditions. And it's not a surprise. And as an example, you could see for diabetes, about, over 90% of older adults have more than one chronic condition. And certainly looking across the various conditions, certainly it could be chronic conditions, it could be depression or other mental health. But these are issues also facing in the United States, like in Japan. One area that's also emerging in the past decade is really drinking, or binge drinking, which is drinking a large amount of alcohol per each time. So this is also an emerging area. And in this case, certainly drinking is defined as a woman consuming 4 or more drinks and men consuming 5 or more drinks on a single occasion. And in 1 year alone, excessive drinking is costing the US economy $224 billion. And certainly it leads to high blood pressure, liver disease, certain cancers, heart disease, stroke, and other chronic conditions. But at the same time, it could also cause a risk of car crashes, falls, violence. And certainly, excessive alcohol use can also interact with prescription or over-the-counter medications. And this is also an evolving issue for older adults in the United States. I'm thinking maybe perhaps in Japan, this is maybe also an issue. Nationally, CDC has a national measure looking at the report card, reporting on key indicators for older adults' health. There are 8 indicators under the Healthy People 2020, which is a national health agenda for nationally. And among these, they include areas such as health status, health behaviors, preventative care and screening, and injuries in terms of measures. And here are some of the select measures in terms of healthy aging in the United States where older adult assessment met the target goals. So in terms of no leisure time physical activity in the past month, so we met the target goal. Also obesity, current smoking, taking medications for high blood pressure, mammograms in the past 2 years, and colorectal cancer screening. So nationally, the rates show older adults are meeting target goals for these key measures. And in terms of, these are some other target goals that have not been met, including flu vaccine in the past year, ever had pneumonia vaccine, and up to date, some of the select preventative services. Also wanted to also mention the opioid crisis over the past decade has affected life expectancy, and more recently in terms of COVID-19 in the past year, they may have also adversely affected healthy aging and life expectancy. Certainly in the US, COVID-19 has led to social isolation among a number of older adults. And sometimes social isolation can be a death sentence for some older adults. Here, I wanted to also briefly summarize kind of the history of the US healthcare system for older adults. In 1935 was the establishment of the Social Security Act, support for old age assistance and insurance, 65 and older. And in 1965, the Older Americans Act established a national aging service network, including area agencies on aging to support state, national, and local levels for older adults across communities across the country. And in 1965, it also included Medicare insurance, which is for older adults, and also Nursing Home Act in 1987, and additional support for family caregivers from 2000. Added prescription drug program for Medicare, which is the older adult insurance program, and also the new Affordable Care Act or Obamacare has added further support for long-term care. And in 2011, also refocusing on the community, healthy communities, a community living assistance support program. So kind of evolving from a hospital healthcare system, nursing home, to also home and community-based approaches. The policy continues to evolve in the United States. And certainly as part of the Older Americans Act to establish the Administration on Aging to organize, coordinate, and provide community-based services for older Americans and their families to maintain social welfare of older individuals. So today, they also have a Facebook site trying to work, the new social media world. And this is, and for the Aging Services, Administration on Aging, they have over 618 local agencies and 256 tribal organizations on aging. And in terms of the older adult medical care, which is Medicare, it also supports those with people with disabilities or people with end-stage renal disease. But it includes multiple parts, a part on hospital insurance, Part A, a part on medical insurance, Part B, and then there's additional parts called Part C, which is the Medicare Advantage Plan, which is a monthly premium for private healthcare systems to contract to provide additional benefits. And Part D is prescription drug coverage. And we also wanted to share, this is one of the leading community-based organizations for older adults called Unlock. It's a program for all inclusive care for the elderly, the PACE program. It's an innovative model that enables individuals 55 years and older, certified by the state as a nursing home care model, but to live as independently as possible. It was founded in San Francisco, but now it's all across the United States. And it coordinates and provides need for preventative, primary care, acute, and long-term care. But for individuals, older individuals continue to live in the community. And this group called the American Association of Retired Persons, or AARP, is a very large advocacy group. It's a nonprofit social welfare organization with a membership of over 40 million that hopes to fight for the issues of older adults and their families, such as for healthcare, employment, income security, and protection from financial abuse. And here I just want to briefly mention, like in Japan, there are different housing options for older adults in the United States. Certainly, independent living, assisted living, continuing care retirement communities, nursing homes, and certainly I'm thinking about affordable places to live. And in the US, there's also an emerging village model, which is like independent living, but living in the place where they where the older adults have lived, the neighborhood, staying in the neighborhood where they live, or place-based health. And certainly in the community services are also a variety, probably similar to Japan. There's a number of services, from meal services to homemaker services, helping with things around the house, cooking or laundry or, other things, chores like going to buy groceries or, maintenance, visitor services, coming to have a nice visit with an older adult, and other services, adult daycare, respite service care, to support older adults. For caregivers that are really stressed and need support and care, for someone to come and help the caregiver, and other services. And finally, I wanted to talk about some of the recent US policy recommendations. One of the key recommendations is really presenting a new Healthy Brain Initiative roadmap. Another is really thinking about lesbian, gay, bisexual, and transgender aging and health issues, and supporting this in the United States. Continue to support physical activity related interventions, mental health and mental distress issues, and also supporting vaccination rates, such as for shingles. These are some of the key recommendations CDC has recommended. Okay. moving forward. Also, some other key recommendations really critical, to ensure, there's adequate training for the long-term care workforce, an adequate number of health professionals in long-term care workforce. This training is critical. National standards are really critical also, as we need more and more caregivers, formal and informal caregivers for older adults. And we also need to think about, in the United States, as our Asian populations become multicultural, more diverse, we really need to support the workforce to also be more diverse and multicultural. And also think about health literacy issues and language access issues. Other policy recommendations also include thinking about immigration and migration policies, as we need more workers to care for older adults, and perhaps workers from other countries to come to the United States. It's really, and to prioritize certain programs also for the most vulnerable, frail older adults, such as indigenous populations, those aging in rural communities, and older adults with certain disabilities, end-of-life issues, and also depression and suicide. And certainly continue to support some of the national health aging initiatives. The CDC also promotes the key areas, including nutrition, physical activity, and social activities. Like in Japan, these are really the critical priorities to really push forward. A critical recommendation in the US is also to really think about early in life. Healthy aging doesn't start towards 65 and older or 75 and older. We really need to rethink the healthy aging model and through a life course approach. The earlier the better. If we could help, children to learn how to, have a good nutrition, good physical activity, and social activities, this will translate when they become older adults and when they become 75 and older, to have good habits toward the later in life. And certainly we need really a community system, to support creating, and then certainly work opportunities that are supporting older adults as well. So especially in rural communities, revitalizing these communities where, there may be more older adults as young people go to urban areas to work. How do we think about, revitalizing these rural communities and building models for rural communities? And certainly, hopefully biotechnology, social media, kind of robotics. I know Professor Kamide has talked about the advancements of automation and robotics in Japan, but hopefully, a combination of initiatives from social activity, social support to automated activities really to support people to continue to live at home and in the communities as long as they can. So that is the end of my presentation. Thank you. And I will leave some of the additional questions for later. And it's really my pleasure to also welcome the next presenter for her research report. And the next presenter is Ms. Yuka Ohata, and she is a master's student in the Division of Health Sciences at Osaka University with a background in nursing. And she will be presenting on locomotive syndrome and frailty in community dwelling older peoples. Please welcome Ms. Ohata.
Thank you. Thank you for giving me this wonderful opportunity. My name is Yuka Ohata, the first year master student. I used to work as a nurse at orthopedics department, so I'm interested in those who have bone and joint diseases. I will share my shown material. Now let's get started. My research topic is the factors associated with physical frailty among community during older people with bone and joint diseases. First, I would like to talk about the background on this study. Japan is currently the longest life expectancy country in the world. The population is aging, and it is estimated that the number of older people will reach to 40% by 2050. Although the life expectancy has been extended, the function of bone and joint is not fully catching up. This figure shows the percentage of knee osteoarthritis by gender and age. It can be seen that the prevalence of knee osteoarthritis increases with advanced age. Knee osteoarthritis is a representative of bone and joint diseases. Those who have it have a physical suffering, especially pain, which lead to a decrease in the chance of going out and cause the weakening of muscles. This figure shows the composition ratio of the main causes of needing nursing care by gender. Bone and joint diseases was the yellow part. In female, it accounts for more than dementia, which was the most prominent cause of nursing care needs. Prevention of bone and joint diseases are very important for prevention of nursing care needs and extension of healthy life expectancy. The Japanese Society of Geriatrics defines frailty as a state in which the person is more vulnerable to stress and is prone to turning points such as life dysfunction, needing nursing care, and death. Frailty is positioned between healthy and needing care. Moreover, it is considered a state where it can return to health independent with an appropriate intervention. This figure shows the risk factors of frailty composed of physical, psychological, and social factors. Bone and joint diseases are the important risk factors of physical frailty, and they cause a decrease in activity of daily living and life dysfunction. However, some older people with bone and joint diseases did not fall into frailty. What is the determinant factors? So this study aimed to clarify the factors associated with physical frailty among community during older people with bone and joint diseases by age groups. This study is a longitudinal analysis of a prospective cohort study called the septuagenarians, octogenarians, nonagenarians investigation with the centenarian study. We call the SONIC study. Psychologists, sociologists, geriatric physicians, dentists, and nutritionists were part of this survey. This study has been ongoing since 2010. We collected data from 70 years old in 2010 and 80 years old in 2011 and 90 years old in 2012 as a baseline survey. Since 2013, we started follow-up survey on a 3-year cycle. I am using data from 2010 to 2012 or Web1 data for my study. The exclusion criteria for this study was that participants have nursing care needs level 2 or more. This slide shows the participants in the present study. 2,245 participants initially joined at the baseline, and while 29 people who need nursing care level 2 or more were excluded. This study examined 2,216 participants. Of them, 1,111 participants with bone and joint diseases, while 848 participants were physical frailty. Physical frailty in this study clarified by abnormalities of one of walking speed or grip strength or both. slow walking speed was clarified as less than 1 meter per second, whereas free grip string was clarified as less than 18 kilograms in female and less than 26 kilograms in male. Bone and joint diseases were assessed based on self-reported by a medical doctor or nurse interview, and they also asked about the specific types. The independent variable are as shown on the slide. The dependent variable is physical frailty. This is a statistical analysis. The subject attributes were compared between the two groups according to the presence or absence of bone and joint diseases and physical frailty. The baseline characteristics analysis using descriptive statistics. Let's move to the results part. This data shows the number of participants in each age group. As you can see, the prevalence of bone and joint diseases increased with advanced age. 40.1% in 70 years old, 56% in 80 years old, and 63.7% in 90 years old, while the individual with physical frailty among bone and joint diseases was 69.8% in 70 years old, 85.7% in 80 years old, and decreased slightly with 84.6% in 90 years old. This table shows the comparison of the existence of bone and joint diseases in each age group. In 70, 80, and 90 years old, the factors show significant difference between existence and non-existence of bone and joint diseases were female. Moreover, in 80 years old, the factors show significant difference between existence and non-existence of bone and joint diseases, living alone, experience of falling, having big hip swings in male, and slow walking speed. While in 90 years old, living alone and having low albumin. Table 3 shows the comparison of the existence of physical frailty among individuals with bone and joint diseases. In 70 years old, the factors show significant difference between existence and non-existence of physical frailty among individuals with bone and joint diseases were having less high in female, while in 80 years old were female having less high, and in 90 years old were having light weight in female. Moreover, in 70 years old, not having osteoarthritis shows significant difference between existence and non-existence of physical frailty among individuals with bone and joint diseases, whereas in 80 years old were having low albumin and presence of osteoarthritis, and in 90 years old were having low albumin and presence of osteoporosis. This is a summary and discussion. In 70 years old, 40.1% had bone and joint diseases. Individuals with bone and joint diseases were more likely to be female. Among individuals with bone and joint diseases, 69.8% had physical frailty. Individuals with physical frailty were more likely to have lower height in female and absence of osteoarthritis. From this result, at the age of 70, it was considered that each specific type of bone and joint disease did not associate with physical frailty. In 80 years old, 56% had bone and joint diseases. Individuals with bone and joint diseases were more likely to be female, live alone, experience of falling, having weak grip swing in male, and slow walking speed. Among individuals with bone and joint diseases, 85.7% have physical frailty. Individuals with physical frailty were more likely to be female, have less height, low albumin, and presence of osteoarthritis. From this result, at the age of 80, being female, geriatric syndrome like malnutrition status and osteoarthritis were associated with physical frailty. In 90 years old, 63.7% had bone and joint diseases. Individuals with bone and joint diseases were more likely to be female, live alone, and have lower albumin. Among individuals with bone and joint diseases, 84.6% have physical frailty. Individuals with physical frailty were more likely to have light weight in female, low albumin, and presence of osteoporosis. From this result, at the age of 90, geriatric syndrome like malnutrition status and osteoporosis were associated with physical frailty. This is a conclusion. In the older people, there was a difference by age in the factors related to physical frailty, and it became clear that the involvement of bone and joint diseases was stronger at the age of 80 and 90. Moreover, a longitudinal analysis will be required to clarify the causal relationship in the further study. Thank you very much for your attention.
Thank you very much for the wonderful presentation. So we will leave the questions and discussions later. So I'm going to introduce the next wonderful presenter, Professor Linda Newhouser, and she is a clinical professor of Division of Community Health and Human Development, principal development and principal investigator of Health Research for Action Center. And we also welcome the Professor Dr. Xiaoming San from Nanjing Youdian University in China. And he is a colleague of Professor Linder and now leads the migrant worker program in China, aiming to the healthy aging. So they are presenting the importance of working across disciplines and using participatory design to develop and implement interventions. So please, Professor Linda.
Yes, I'm very glad. I'm going to share my screen now. Yeah, so I am delighted to be here with this collaborative, and I really enjoyed hearing the presentation so far. There's so many big challenges, and I think what I would like to talk about, and along with my colleague Xiaoming Sun, is a few things that are in the way of background for when we think about interventions. So I will start out just by introducing myself a little bit and why I'm interested in some of the topics we'll discuss today. So I will not go over and repeat what Winston had to say, but I'm the co-principal investigator of the Health Research for Action Center. And Winston has already mentioned about how we work. And our focus is a lot on interventions work. We try to mix research and interventions together and have success doing that. So one of the things we do at our center is focus on participatory work. So we work very closely with the end users or the people who are supposed to benefit from an intervention and the many people who are supposed to implement it. So participatory design is a very important thing about what we do. But before I get into this, I would like to have Professor Sun introduce himself.
Oh, okay. Thank you, Professor Linda. I'm Xiaoming Sun from Nanjing, China. So my working unit is the School of Sociology and Population Studies. Nanjing Yudian University, just for more than 30 years. I'm once working with Professor Linda to implement a participatory wellness model in China, particularly for the migrant workers in the city, because of the many young people moved from rural area to the city to work there. Just yeah, we have a long time cooperation before.
So we have been working together for many years now, doing participatory work. And I will talk a little bit about one of the projects that we were doing in Changzhou, China. And I would like to introduce the reason why some issues are very important to think about if you're going to do an intervention. So one of the things I do is I study interventions, and unfortunately, I have found that many of them do not work. So there are very good intentions that we all have about developing programs, but often they're not successful. And there are a number of reasons for that. And so today we'll talk about some of those reasons and what we can do. So one of the underlying problems of the things that we try to do is that these are very complex, or sometimes these are called wicked problems. This was a term that was developed at the University of California, Berkeley. I don't know how that translates into Japanese. Mai Kabayama. How do you translate wicked problems into Japanese? You are muted.
Okay. I was thinking, ウィキッド。上出先生、何かありますか、アイディアは。トリッキーじゃないな。ちょっと
Okay, wonderful.
Sorry.
So, the reason why the term wicked is good is because these are things that really bother us. We have complex problems and we can't figure out how to be successful. So in the 1970s, we had this name of wicked problems develop. So I'll talk a little bit about that, and then how we can do better. One is to work across a lot of disciplines, research disciplines in academics, and also sectors in society. And very important to use participatory design approaches if we want to solve some of these complex problems. And then we will mention a few examples from China and the US. So here are the wicked problems. I cannot repeat that term in Japanese, but Professor Kabayama has very generously talked about that. So there are simpler problems that we try to work out, but complex problems or wicked problems have a number of characteristics. And one is that they're very unique and they're very hard to define. Every time you're dealing with a complex problem, like healthy aging, it takes you into other problems. The definition of the problem is going to really depend a lot on who's defining it and their values and their views. Sometimes the people who are expected to solve a problem, these could be maybe policymakers, they could be researchers, they could be people who run programs in society, like health programs or social programs. They personally are disconnected from the problem. So for healthy aging, the people who are solving the problem, they are not necessarily older adults themselves. So they're not really there with the problem. Sometimes the people who are solving problems are also helping to cause it. And that is a hard one to sometimes think about, because we all intend to do our best, but we may be causing problems when we try to solve them. And there's no one way to solve these kinds of problems. And number 7, this is a very difficult one to understand too, because you can't really understand a problem until after you've designed and tested a solution. That's the time when you really know what you were working with. These problems also, they change over time. They're never solved. So healthy aging is always going to be changing dynamically in all of our countries over time. And we can never solve it. We can just try to stay on top of it and do our best. So some of the examples of complex problems are the following, climate change and nuclear weapons and hazards, politics, healthcare, and of course, healthy aging that we're discussing today. So if we think about trying to work across many disciplines and many perspectives, as I mentioned, that's really important because often our interventions fail because we've only looked at one issue or a few issues and not all the factors that are affecting that issue in people's lives. One example of that is looking at a problem and deciding it's a healthcare problem rather than a broader wellness problem. So I really like the way that Professor Kamide looked at the issue of healthy aging, because he talked about all the many disciplines that are involved in healthy aging, all the many factors that you have to think about. It's very comprehensive. The second reason that interventions fail is that often we design programs where we don't really involve the end users or other stakeholders that need to be involved to do something. So we might just stop here for a moment and think about whether in the healthy aging programs that we are designing, are we really having the people that we hope to help involved in the design? And if they're involved in the design, are they really involved in the design intensely? Or do we design a program and then we kind of go to them and do a focus group and hope that we've designed it well? So these are very important things to think about here. There's a term that has emerged internationally that is very important, and it's called transdisciplinarity. What that means is working across disciplines and sectors in society. And again, I will ask Professor Kabayama if transdisciplinarity has a translation in Japanese.
Maybe 学際的? 学際。いろんな分野がこう入り乱れているということです。
Okay, well, I'm very glad to hear that. I'm a member of a couple of international collaboratives, and I would recommend that people at this symposium might want to join some of those. And they are looking at ways to solve complex problems by doing several things. One is bringing together all the disciplines that you need to think about regarding a problem, and then bringing together the end users or the people who are going to benefit from an intervention, bring them together too, and all the people who implement it, so that you have like this diagram here. You're bringing together on the right side people from disciplines, and then from the left side, people that are actually to benefit in society, people who are practitioners and implementers. And the idea is everybody should work together to define a problem and the solution. So there's a lot of work internationally about what this means and what can happen and how we can do better. And at the end of this presentation, I have recommended a paper about this that Professor Sun and I and our colleagues have developed that talks about these issues. So we might ask, if we're trying to integrate knowledge from a lot of different sources, what does that really mean? Well, one way to look at that is that we are trying to integrate knowledge from a lot of different disciplines. We're also looking at different perspectives. We're looking at different ways that people have of thinking about things. I'm thinking here of Winston, when you mentioned how people think of healthy aging. You had a very good example from the focus groups. If you had not done that research, you wouldn't know that different people think about healthy aging in different ways. So very important. People come from all kinds of cultures. Our societies are so multicultural now that we have to constantly think about that. And then everything we're doing is involved with a lot of different systems. So there are many things that we're trying to do if we're going to be transdisciplinary. It's a very hard thing to do well. So I wanted to ask Professor Kabayama if you wanted to translate into Japanese anything so far, just in case not everybody who's at the symposium understands English that well.
Maybe everyone can understand very well. 誰かわからないことがある人、遠慮なく、言っていただきたいんですが、大丈夫ですかね。大丈夫だったら、OK のマークを出してください。And anyone? Okay. Okay, many people.
And please put a question in the chat box if you would like to have something, more comments about something. We can be very casual here. So I mentioned at the outset that I am very interested in participatory research, and so is Professor Sun. And besides looking at a problem through a lot of different perspectives and from a lot of different disciplines, we also need to do better in being more participatory. So I will talk a little bit, along with Professor Sun, about how to do that. I think these days, everybody talks about being participatory, but often it's not very deep. So we are just maybe at the edges of being participatory. So I'd like to mention first a little bit of the history of participatory design. And this actually comes from two different places. One is in the 1960s, there was a whole movement about participatory design that came from engineering and architecture and the different socio-technical sciences. So they found that you have to have intense participation in order for whatever you're making to work, whether that's a building, you're making a car, you're making a computer. If you don't have intense participatory design and keep revising things as you go along, it's not going to work. The second movement was one in sociology and anthropology, and we can call that action research. So also in the middle of the last century, there was a lot of interest in trying to move away from just having researchers design programs and become more participatory with those who are going to be benefiting from them. So these two movements here are actually overlap a lot, but they're different in terms of where they originated. Now, many of these participatory approaches are being adopted in health and business and policy. So one of the things that we talk about is user-centered design. There is a long tradition of that in Japan, especially in manufacturing, which is quite interesting. And we have been influenced in the Western countries by what's happened in Japan. So these use build and design loops. So these loops start with building something to solve a problem, evaluating that, identifying more problems, and you keep working in a loop like this until you get to a good solution for your problem. So I wanted to mention there are many, many types of participatory approaches, participatory design. And I wanted to talk especially about design thinking. And Professor Kabayama, is design thinking a term that you use in Japanese? Design thinking.
Design thinking. With design thinking.
It's a
maybe in English is okay.
Yeah, okay, we'll use English here. But you probably have a term in Japanese. So this is a very interesting story, but Steve Jobs and people at the Stanford Engineering School, David Kelly, they came up with a term called design thinking. And this is one where you join the users and stakeholders in a participatory process where you identify problems and you create solutions. So there are 5 steps to this approach, and I'll go through each of those. You can see them here, and each one has different ways to work on it. So the first step is to empathize, and we don't often do this in research. We don't start out with empathy, but empathy is very important to look at any kind of a problem. And so you would want to start with stories and people's emotions and so forth, and then gather data about that, maybe through formative research. The second stage is to define. So you would define a problem here, and you would come up with a big goal. Healthy aging in some particular context could be a big goal here. Third stage is to ideate or look at all the solutions that you might come up with without trying to just think about 1 or 2. And then you try out your solutions. This is where you maybe do pilot tests. And you keep doing this with the users until you get to a point where you think something is working. So I'd like to give an example along with Professor Sun of how we use participatory design to solve a really big, complex problem in the city of Changzhou, China. So this is not a healthy aging example, but Professor Sun is going to talk about how he took this model that we have worked on and they are considering to apply it to healthy aging programs in this city. So the migrant worker, I'll just show you first of all our group here, which includes Professor Sun and Winston Seng. Wonderful colleagues, you see some of them here. And the big problem here is that there are in China now over 250 million people who have moved from the rural areas into the cities, often to work in factories. And these are called migrant workers. And they're very vulnerable population because they have lower education, life skills, social networks. Maybe they don't know their legal rights. They also have a lot of issues they face, like infectious disease and depression, pregnancy, discrimination, and so forth. And this problem fits our definition of complex because there's many causes for the problems that this group faces, very socially complicated. It's also an emerging problem that's changing very fast. And as I found when I started to work on this with Professor Sun, that there had been many efforts to try to solve this problem. But many of those, as I just mentioned, were too narrow. They didn't look at all of the issues, and they hadn't really involved the workers themselves or the managers or many of the other stakeholders. And Xiaoming, would you like to comment on this?
Okay, thank you, Linda. So would you please show back to the slides with the picture of the logo of the slide? I would like to.
Oh, the logo. Let's see. Yes. Okay.
I'd like to talk about the story of the logo. Yeah. To my. So I'm very happy to see it again. You know, just make me recall something. So by using the participatory methodology, you know, the traditional way in China is, China is a very centralized country for almost everything. But after a marketing system introduced to China, so the things is changing. But for us, particularly for our scholars, so we still use very much like to use the way to design activities, to design some special activities for our pilot study places. But when we met Professor Linda, and Linda introduced this participatory theory to us, so we tried to combine this one with the traditional Chinese way. So here's a very special case example. You know, on the right of this slide, you will see a logo with a red smile face with very simple, two things here. So I clearly remember that we invited some very professional designer to design more than like 6 or 7 different logos. Some of them are very fancy with very deep meaning about like environmental protection, healthy, everything. So I bring these 6 the logos to the UC Berkeley. Linda, do you remember that we had a special meeting there, and you invited many professors and researchers from the center to discuss that. We would like to just vote which one we prefer to. So we vote a special one. It's not this one. So we all of us thought that would be the best one. But after my being back to the Changzhou, I showed all the logos to my migrant workers. So I said, which one do you like? So the most of the migrant workers that selected this one, just this one. So very simple, very easy to understand. this logo is for the special wellness house for each factory. So for to organize their activities by themselves. So it's finally, it's a really conflict between the top leaders, managers, and the common migrant workers. So I made a decision. So we thought we just use the participatory way to let the people who will have intervention there, they made their decision to select the logo. So finally, we select this one. So this is a very typical case, story for us, particularly for the academic people to people understand that the participatory way is really a good way for us to do the action program. Okay.
Yes, and the example you brought up, Xiaoming, is very good because at every step in this project, we had to rethink our ideas. And the workers and stakeholders often had a much different idea.
Right.
So one of the things
up to now, Linda, up to now, I visit the places for every year, ask the new migrant workers. Everybody said that one is the best.
Okay. And so many have failed. So the story here is that we started out to build teams with many disciplines. We had to look at all the disciplines that might be relevant for these workers. And you can think about the same thing if you're doing a healthy aging program. What are all the disciplines? And the programs before we started this had just focused on health. But we found out that really you needed social services and policy and communication and law, education, labor, employment. So many different disciplines we would need to draw from. The same is true of healthy aging. And we looked at the stakeholders. So in the past, the health professionals and the government officials were the ones who were going to design the programs. But in this project, we of course went to the workers and the managers and the media and all kinds of different people got involved in working on this project. And we have continued to refine the project over time and then think a lot about sustainability and expansion, which is another big problem here. So we used a lot of different participatory methods. Some of these are common research methods like focus groups and interviews, surveys. The third one here is a very important one that for this project, and that is that because many people were not familiar with participatory design and a wellness approach, is that we had workshops to train people on what it is, why it's important, and how to do it. We set up advisory groups of many stakeholders, and they continued to provide a lot of very participatory ideas as the project moved along. And then all the partners were involved in designing and revising the interventions. So here's a very early, at one of the workshops, we introduced the idea of people identifying all the worker health and social problems. So you can see that we have a big group of people. They are working to identify problems and then they're identifying solutions. So this is a design thinking approach, which is very effective. And from this activity, we got a lot of information about problems that nobody had really thought about beforehand in prior projects for these workers. They found out many more problems that needed to be solved. And they also came up with many very practical solutions, which were quite amazing. I won't go through all of the details about this, but through this participatory process, the many participants coming from different backgrounds, they came up with 3 interventions. One was a wellness guide for workers. And this is a booklet designed by the workers and all the different partners. And it has information about health and wellness and social issues. It's something that we have done in the United States with older adults. We have done participatory work with older adults to develop booklets like this that talk about many issues that they face and then what can be done. And those have been very successful. The second intervention was something called a wellness house in each of the factories. And these were designed by the workers and by the partners. And they were intended to address a lot of the gaps that other efforts had not done so well. So not just thinking about health, but social connections, learning, and so forth. And these are a very novel idea that I've never heard about anywhere else in the world. And it's amazing to me that through the participatory process, the workers and others came up with something entirely innovative. And then there is a volunteer program too. So these are some pictures of what happened in the participatory processes. You can see a lot of work in small groups here to draft ideas and then to continue working on them. And this has taken place over the years. People are constantly coming up with new ideas and improving those, looking at new problems and solving those. Here's an example of a design thinking activity that takes place there's a yearly meeting of the partners in this project. And so you can see at tables here, these tables include a lot of different partners. There are workers in a factory, there are health professionals, there are government workers, and all different kinds of people are getting together. And if you look at on the right, they're doing 2 things. They're working out problems that have come up, and then they are also working on solutions to those problems and taking those back. So this kind of process has been extremely effective. And I wanted to have Professor Sun talk about this a little more about the wellness model, is the way this participatory model, and some of the ideas you have for applying it now to healthy aging programs.
Okay, so what Professor Linda already told the details about our migrant workers, the wellness model. So we would like to apply the similar principles of this wellness model for the migrants. So first, we would like to set a wellness house for the elderly people in our selected communities. Then for the group activities for the Chinese elderly people. The traditional way in the Chinese retired people, after retirement, they would like to get together when they have the time. So, but they do not have the place. So they just visit some shopping center or some bank, many places to go, even take the public bus freely. And it's young people, it's just, don't like it. So we need to set a place for them to work to play together. The second one is we would like to use the way to let the old people, the elderly people to design what they like to do, like dancing, singing, chess playing, cooking, and something. So we will use this way by themselves. Yeah, and also the program is that in China is very big. Just like Professor Perry mentioned about that in China, is many, the oldest elderly people, they don't want to go to the.
Xiaoming,
Yeah,
it's a little hard to hear you. I don't know why.
you cannot hear me?
Now we can hear it. This is great.
Oh, okay. Sorry.
Before it was a little, I don't know, something.
Okay, so I repeat it again. So we will set a wellness house for the elderly people for them to, play together during the daytime if they have time. So the Chinese people, the retired people, they would like to get together after retirement. So, but no place for them. So they just went to the shopping center or banking place somewhere to spend their time. So we find this way. And another thing is that we would like to apply the principle of the wellness model to let the elderly people to design activities by themselves, like the dancing or singing or chess playing or cooking, something. And another, the third one is we would like to provide daily care, supported by the neighborhood services for the disabled elderly, because the Chinese people some financial problems and something that don't want to go to live to their living places, to the special place for them. So we would like to provide this, and also we would like to connect to the local the community hospitals to provide some emergency care or the health services for the people. But all the activities we would like to let the elderly people to be involved in. That is the primary thinking ideas of us. Okay.
Yeah, and it's really hard to say how amazing it is when you see what participatory design can do. If you're really using it intensely, it comes out with innovations that you never think about. Like one of the things I was wondering about, Professor Kamide, when you were talking about all the services that are provided to older people in their homes,
Yes.
I was wondering, especially during COVID, it's very hard. So is it possible to use maybe some kind of biotechnology to have televisits so that you can get to a person's home without actually being there? And these are the kinds of things that older people could work together with communication experts and use participatory design to come up with programs like this.
Yes. So, maybe my understanding. So I think a participatory design is in a home medical care. So we goes to their house, and sometimes they goes to the place to gathering the older people. It's a daycare center or something like that. So I think that's they participate in the older people's parties, the place. So they have connect with the other older people. So that's it's very much working on the long-term care service. So not they only living in a house. Of course, so if they had the severe disabled, so they cannot go out. But if they can go out, so they are going to the place to gather the older peoples.
So the idea here is that if you want to improve anything you're doing, it might be like the home services they get. If you involve the people who are getting the services using some of these very sophisticated ways of doing design work, I think you would find really great ideas to improve them.
Yeah.
But it does take a lot of attention to the methods that you use. And, you know, it's quite amazing, but everything we hear about can be improved this way. And there's so many participatory methods that are out there that many people don't know about. So I wanted to just go to give a recommendation under the resources here of suggesting that people go to ideo.org. This is a design thinking company that was started by Steve Jobs and Stanford University. And they're all over the world now. They're very successful. There are many free resources and videos and all kinds of things that are on this website. And if you want to learn about really great participatory methods for your project, you can find all kinds of ideas on this particular site. And we will provide a PDF of the chapter that you see here, which talks about in detail more about participatory design in the China Wellness Project. Again, lots of approaches that might be helpful in other programs in healthy aging. So that is all that we wanted to say here, and there may be questions about some of the other presentations. We might have a few minutes to talk about that. This is all up to Professor Kabayama because she is the one who is running the clock.
Thank you very much for the wonderful presentation and really impressive for the participatory design and research with interventions. So maybe I'm going to pass the ball to Winston, Professor Winston, to have the discussion together. Or
so maybe we can have a few minutes of discussion. I know it's past the time, but if you could stay a few minutes, we're open to your questions or any other discussions. Feel free to speak up or feel free to put your questions on chat. And we're happy to respond to any questions or anything you wanted to share about today's symposium. Is there someone who have a question or something? Please go ahead, Professor Kamide.
So thank you very much for wonderful presentation, Linda and Professor San. So social participation is, I think, a very, very important in healthy aging, and maybe even in assisted living people. So, but some people cannot participate in, the parties. So I think old men and it's very isolated. They go to everywhere, just in their house, watching television, or they don't participate in other activities. So do you have any idea to, to let them participate in a, okay.
Well, this is a very good question, because at the beginning of the project with the migrant workers, many people said they will not participate.
Mhm.
They're not interested. And it was hard at first to get people to participate. And then when they started and they realized that we really wanted to hear their ideas and their solutions, then they became very active participants. So I think with older adults, there are many challenges. And, it's not only the older adults, but if you look at their families, their caregivers,
Yes.
they also need to be involved in the design. And you can design people, let's say you can use the telephone or Zoom or many ways these days to get people to participate. You could imagine that our group here today was all older adults, and they were all given a problem like, how would you improve your assisted living program where you live? You could do a program, you could have design thinking approach just by having a Zoom call and using techniques. Xiaoming, what do you think?
Okay, so it's a good idea, but it's a different generations for our migrant program, worker program, and the future elderly program. I'm not sure whether it works well or not, because in China, the elderly people, the generation, the baby boom generation, China at that time, was relatively poor, and they had very low education. So that is what we're worried about. Some of them, they could not use the smartphone. So, but for the younger elderly, like between around 60 years old, less than 70 years old, most of them like get used to right now to use the WeChat. So the WeChat is a group, is a group by telephone. So it's the way probably we will use in the future. But for the elderly, like the Professor Kay worried about, we probably will use the other different way to do so. Because most of them, they could just stay at home, and they do not have the skill to master the using the telephone. This is what we need to do.
Very good idea to use WeChat with people. Anybody who's on WeChat, and the caregivers will be on WeChat.
Yeah.
And I think involving older people, I will just mention that a project that our center at Berkeley has done that Winston mentioned is called the Villages Project. And this is aging in place project where we take people in assisted living and then use participatory approaches with them so that they have, they start identifying problems at assisted living and identifying solutions. And this has been very successful to help people age in place and to understand the problems they're having that maybe the people who set up the assisted living didn't know about. So it's been really interesting to hear all the things that people talk about that they have problems with, and then all the solutions they have. So the Villages program, which is now in different parts of the United States, this has been quite successful to give power to the people who live there to create the kind of space that works for them. And you could do that, Xiaoming, with a wellness house, a community wellness house. We certainly, go ahead.
Age specific, even for the elderly, like 10 years of age, 3 categories to find the different way to use the participant methodology.
And we have a question here in the chat.
Yes. So is there I'm going to go along with the kind of the order of the questions. And I know Marlon also was raised his hand. So just for one of the first questions was in the US, the gap between the rich and poor is wider than Japan. Heard some poor people cannot access to health care. So in terms of the gap in terms of aging in the US, I think certainly this is growing. I think this is a growing gap in terms of the challenge between the rich and the poor. And certainly there's a technological divide, and also in kind of the changing dynamics of how aging services or aging in place is changing. So certainly it is a very big issue. And if they cannot get access, I think one area in the US where anybody can get access to is what we call a community health center system, where there are certain clinics where anybody can go get health care. But it's also a long line, long wait. Sometimes it takes months to get an appointment. Um, but this is the challenge in the United States. You can't get health care right away. And sometimes long-term care facilities, you need to get in line for months, sometimes years. So this is a challenge, especially for those that are poor. And then thinking about support for US government recommended for suicide and depression, I think this question was from Nakamura Yuko. Thinking about, these issues, certainly, there isn't one good answer really, but really social isolation is the main issue for older adults especially. So how do we kind of address social isolation? I think like the social activities through the senior centers have been a very successful model. And then the multi-generational approach to aging in place through the villages has been another successful model. But, trying to work in the previous model called PACE has been a successful model, but it may not, and we're finding that different cultures, older adults may be different. So the village model hasn't really worked for some of the different communities because there's a certain culture to that, meaning older adults want to be independent and they don't want their children involved or others involved. They just want to be independent living kind of approach. And that doesn't work well, for example, for some of the Asian American cultures in the United States, where it's very dependent on their children to care for their health. So just as an example, but certainly this is a question. And then there's a follow-up question for Linda. So please go ahead.
Yes, I see that from Yuko Nakamura. Yes, this is a very good question because the wellness guide that you saw a picture of there, this is a model that we developed out of our center over many years. And in the United States, we did a California-wide project to take an original wellness guide and have it adapted using the participatory process for Chinese American groups. So we used exactly that participatory method. We had Chinese Americans get together in small groups and help design their own wellness guide. This was in Chinese and in English. And we learned so many things from this process about the problems that they were facing that might be different than a different culture, and about the solutions that they thought would work for them. So when we began work in Changzhou, there was a lot of interest among people there about the idea of having a guide for workers. But what we learned in the United States was you can't just have one guide and use it for everybody. You, just like you said, Yuko Nakamura, your point, you have to have the people themselves design it. And what we learned in the project in Changzhou was that you needed a lot of people to design it. The workers had to have their input. The professionals had to have input. Many people had to be involved as a group to design something good. And we had a few early problems doing this because the people who normally write health education materials are health professionals. And when they started to get involved, they wanted to write it the way that they like to write things. But when the workers looked at the draft, they said, no, this is too complicated, the language. These are not the problems that we have. These are not the solutions that will work for us. So it was a very interesting situation where we had to change back to a much more participatory way. And Xiaoming, you might want to comment about this.
So my working experience that, like China has our own culture, US culture and Japan culture. So when we applied the theory or principles of participatory theory, so we must, consider our own culture. It's kind of not directly copied. Just we need to know what the things happen in real Japan or in real China. So then we find a way to combine them together to create a new way of the participatory methodology. So it's the principle is the same, but the content might be different from country to country. So this is my working experience.
And it's been very interesting that over time, we are now in the 3rd or 4th edition of the Wellness Guide in Changzhou. And every time it's revised, all the people are involved in making it better, pointing out things that don't work that well. And every edition is better. And I'm always amazed because they come up with ideas that I would never think about because it's their ideas and it works for them. So I think something like this could be very interesting in Japan for different populations. And Winston, I think also in the villages, it would be quite interesting to try something like a village wellness guide. I don't know what you think.
Yeah, very interesting. I know, Marlon, did you have a comment?
Yes, do we have time? It's getting quite late. I can...
Probably last comment, yeah.
Okay, well...
Please go ahead.
Okay, so 2 quick comments. One, again, thank you everybody for wonderful presentations. One question is similar to what Yuko Nakamura's question to Winston, to Professor K. The cultural differences between the United States and Japan are to some extent based on the fact that Japan is much more homogeneous, and what Winston referred to, that we have a much more patchy set of services in the United States because it's extremely multicultural, and what applies to one doesn't apply to another one. So it seems to me from your presentation that that may be one reason why Japan is able to do something much more universal. So my question is it so? Is this kind of support, social support, really accepted by all Japanese pretty much? Or is there some resistance? Do people maybe don't want to be helped? I just was wondering if you could clarify that a little bit for the rest of us.
Yes, thank you very much. So very good question. So I think most of all the people are accepted our service or service for all people. But some people feels resistant. I don't wanna care. I'm very independent.
Mhm.
Even they have very disabled physical conditions. So that the medical staffs very, very, struggling with those people. So they they think independent, but they
And
had many times of the falling, so many times go to the emergency calls. So we need, we think they need for help, but they don't want to help.
Right.
so if you ask them what would help them, if they are the designers, then you would find out something that would work for them. We had the same problem with the workers in China. At first, they weren't necessarily that interested, but after a while, they're yes. So this could be very interesting to find out why the people you want to reach are not interested. Maybe the program doesn't work for them.
Yeah, I think so. So we have to change, and maybe we will refer to the American style. So it's a very different, ethnic it's an issue. So in Japan, it's a very homogeneous. So Professor Amao said. So we have to modify and upgrade, referring the multicultural countries way to access. Thank you very much.
So just to close the symposium today, certainly, we learned different lessons from different countries, thinking in Japan, a universal healthcare system and long-term care system, and certainly discussing frailty stage as a key intervention stage. On the other hand, in the US, really thinking about early in life as the starting point for addressing healthy aging, kind of different conceptions of what is healthy aging, for example, between Japan and the United States. And certainly we're hearing also, about the active living Japanese living super aging society, living to an older age and still healthy and active, perhaps as a productive worker or as a volunteer. Where on the other hand, in the US, maybe not quite there, and certainly not in China yet, compared to how the super aging society that Japan is there. But clearly seeing some of the historical development into the policies to support aging and long-term care, and kind of as we move towards a healthy aging model in all the countries as we're moving forward. Certainly, a critical point that the last presentation I talked about is really interventions don't work unless we do design thinking and participatory design. So there are many lessons we can take from here moving forward. Also wanted to remind everybody that we have a follow-up web symposium on January 19th from 10 to 12 Japan time. And we will have presentations by Professor Kabayama on social capital and aging society, and other reports about health disease and frailty and economic status, hypertension, from some students in the health sciences at Osaka University, and also a special lecture from Dr. Marlon Mouse on physical activity and determinants of healthy aging. And closing remarks from Professor Kamide, as well as special remarks from Executive Director Dr. Genta Kawahara. Please join us for our next symposium. Thank you, everybody.